welcome to all Gold viewers who are here with us today. I'm Kristen Schwartz, licensed midwife and one of the MCs here at Gold. And I'm very excited because we're going to talk about one of the presentations from the Gold Summer Learning Day 2025. And I have the wonderful Effath Yasmin here with me. Welcome, Yasmin. It's so good to have you back here at Gold.
Hi, Christine. I'm very privileged, like always, to be here with Gold.
It's wonderful to have you. Your presentation is titled Beyond the Sensory Defensiveness, a nervous system approach to managing oral aversion in infant. I want to dive right in just a moment. That's such an exciting topic. But first, give us a short background about your work because I find that very important. You know, it's important to know your lens on this topic. So tell us a little bit about yourself.
Well, it's been about close to about going to be 18 years now that I moved into doing this work, and it's been a life's calling. And my daughter's pregnancy, my pregnancy with my daughter is the one that really turned my life into this direction. And there's no looking back, Christine. So I'm so glad to be here. Yes, and I live in Mumbai. Been doing work with mothers and babies, especially around birth trauma, with tongue ties, and also looking at issues where babies require support from having difficult feeding to returning back to breastfeeding. And that would also mean something that I'm covering in today's topic, which is oral aversion.
Oral aversion. So you are a biodynamic cranial sacral therapist, and of course you're
Absolutely.
also a IBCLC, right?
Yeah.
So all these you're putting these wonderful skills and your knowledge together, and I love your holistic approach that how you tackle the topic here. Let's talk about oral aversion in infants. So how does that typical present? And sometimes that can be, I can imagine it is also very traumatic, of course, for the baby, but also for the parent because it must be very, challenging to see that the baby does not want to latch or something is going on. And I can only imagine what that means. So for the parent as well. So talk a little bit about how that typically presents.
So when we looking at oral aversion, Christine, I think what is very, very important to be cognitive about and be aware of is it's not just to do with breastfeeding, it's to do
Mm,
with feeding itself,
mm-hmm,
which means that babies are going to refuse to have anything around close to the mouth. So
mm-hmm.
there's a sense of danger. There's a sense of rejection. There's a sense of moving away from anything that comes close to the mouth. So that is what is called an oral aversion, and that can be many different factors that causes that. But when it becomes an oral aversion, and the challenge is that it's not just the fact that okay, mother is not able to take the baby towards the breast and there's rejection there, but this baby is going to refuse to feed from any other alternative methods as well,
Mm-hmm.
which would mean that it puts us, both the parent, the baby, as well as the practitioner, in a challenging situation because babies need to be fed.
Absolutely.
And that means it's almost an
Mm-hmm.
emergency situation because babies are refusing to take any kind of feed, and it's challenging to regulate the nervous system in a way to even get some amount of feed for the baby. And usually the doctors are looking at certain amount of food that needs to go to the baby per day because they want to see a weight gain.
Again.
And that puts a mother or a parent in a panic situation because so usually this is the presentation, Christine. So the mother would say, my doctor expects me to give 500 ml a day, and I'm hardly even able to get to 200 ml.
Yeah.
And that can be a huge burden, as well as
Yes.
sense of responsibility, and a massive amount of guilt the mother goes through
Yes.
because she does not know what to do when something is expected, and she thinks that she's going to harm her baby because she's not able to get through with giving that much amount of food for the baby because the
Mm-hmm.
baby is refusing to feed. right? The
Yeah.
only way these mothers get through, or the parent gets through, to even get certain amount of milk for this, for the babies who have a presentation of oral aversion, is having to put the baby to sleep. And that can be challenging, because if the baby is hungry, the baby can't sleep.
Yeah.
And
Right.
it's a vicious cycle, Christine.
Vicious
It's a
cycle.
vicious cycle.
Yes. Oh,
Yes.
that's yeah, and you're right. It is an emergency because, babies need to gain weight. Talk a little bit of what triggers this oral aversion, because I can imagine this is like something that can affect a child, a baby, an infant for the rest of his life, right? I mean, this is something that is goes so deep.
Yeah.
Where does this come from? And I know you're working really hard to help and with this situation, not only for feeding but also for later in life.
Right. So they're multifactorial. Like every other condition, this is also multifactorial. So there's no specific thing that triggers off into a
Hmm.
oral aversion. But definitely there are some things that stand out. And what this stands out is any surgical procedure where there is pain that can be experienced by these babies can trigger off an oral aversion, or anything that is worked within the baby's mouth. For example, if there is some oral exercises that are done for a newborn, that's something that can be seen as a danger for the baby, and the baby can experience an oral aversion because of what we do as an intervention. So
Hmm.
there are some babies who are put through some exercises, probably in preparation for a frenotomy, for example. It's just a case in point. So if it is to do with preparation for a frenotomy, there could be some work that's done orally just to prepare the baby for a frenotomy. And that in itself can trigger off an oral aversion, because you're
So
working deeply
in the
into the
mouth.
mouth.
Hmm.
Yeah, you're working in the mouth, and this area can feel, sensitive and vulnerable for a newborn, and
Yes.
which often requires us to be careful about just into. Yeah, and this is the reason,
Hmm.
Christine, that we
Yes.
often tell the parents not to use a pacifier or anything else,
Hmm.
even a bottle for that
Yeah.
matter, because giving a bottle for a baby who we have a desire to breastfeed or have
Yeah.
an intention to breastfeed can sometimes downregulate the whole process.
That is such an important point, Yasmin. I'm a midwife, so even we don't suction anymore because of that, because of oral aversion, right? Unless it is absolutely necessary, something is going
Right.
on, and it needs to be done. But like it used to be routine suctioning of nose and mouth, and we don't do that anymore because of that, because we know that
Because
this
of that.
cause extreme damage and of course interfere with breastfeeding and have other issues
Right.
following that as well. So well-meaning exercises that you mentioned, many parents are probably not even aware that this could cause, they want to do the best for their baby, maybe
Absolutely.
even exercises. I can imagine situations where there is a tongue tie and parents, before deciding, maybe do we want to have a frenectomy, let's try all options first before we do surgery, maybe we do
Yes.
exercises and such, so that we need to be careful as well then.
Absolutely, absolutely. And this can also be like the one that you mentioned about suction, for example. Not every country, I think we are still at a point where this is seen as a routine
Mm-hmm.
procedure
Mm-hmm.
of a suction right after birth. And that can also lead to a lot of oral aversion,
Yeah.
especially rejection of the breast, as well as sometimes even the bottle feeding, Christine.
Yeah.
And post-frenotomy care. Post-frenotomy care is another very sensitive area of work where the practitioner requires to be very careful about looking at the history of the baby, what kind of experience the baby has had during the birth, during labor, after birth, and postpartum, if there has been a separation between mother and baby. So how has the breastfeeding been established or not established? All of these
Mm-hmm.
things will play a role in terms of factoring in when we want to do an intervention, and sometimes intervention is required. We
It's
really
required.
can't,
Yeah.
we are not going to run away from that. But having said that, I think it's very crucial to be sensitive in the approach, and being trauma informed, Christine, can make a
Yes.
it's a make or break situation. It's really a game
Absolutely.
changer. And that's
Trauma
what we're
informed.
looking at.
Yes.
Absolutely. Trauma informed care is crucial. And I think it really can break or make the situation for a practitioner. and for a parent for that matter. And if we can incorporate that in our care around the procedures that we do, that can be a newborn baby, like a suction, for example, or for that matter, if a baby is on a bottle and having to move towards the breast, that kind of confusion that's happening there, or babies refusing to be even on a bottle or the breast, that situation, or preparation for a frenotomy, for example, or post frenotomy, all of these situations can be informed by what we will be discussing in depth in the presentation. So I look forward for
Absolutely.
discussing that.
I'm looking so much forward to that too. You have case studies, right? You have plenty of videos where you're showing what is happening and showing your work. So what can practitioners actually do? I know you will talk about that in the presentation, but just give us a little bit of a snippet there. So we learn
So,
about this topic now, and
yeah.
now we're like, oh my goodness, I want to make sure that I'm not doing anything wrong here or that I'm,
Right, absolutely. Because every care and every practitioner really wants to do a well-meaning care. They
yes.
all have the right intention, and everybody wants to put their best practice forward. Because we want to serve the communities that we are actually serving. So, having said that, I think what will be the key theme of the discussion will be about the approach.
Mm-hmm.
The approach really makes the difference. How can we engage baby's cooperation while we
Mm,
respect the autonomy of the baby, as well
love
as
that.
achieve the goal that we want to achieve?
Yes.
Because we really need to do some interventions. For example, exercises that we might need to do, or wound care that we might need to do. All of these are essential
Mm,
sometimes. And if it is essential, how can we collaborate with the baby,
yes.
and it's a biodynamic approach, Christine. The
Love that.
biodynamic approach allows us to recognize the readiness as well as the cooperation that can allow us to work more smoothly. And this requires a little bit of more sensitivity towards the approach. I think that's more important to recognize and to be cognitive about and to acknowledge that. And this can really change the way the parents can be feeling more empowered, is what I have
Mm-hmm.
noticed. That sometimes the practitioners with which the parents have worked earlier, Christine, where some procedures or some exercises that have been given for the parent to exercise at home has not really gone very well, and even not just traumatizing the baby but also traumatized the parent in,
Right.
in the bargain of that situation, because it's been difficult for them to go through that process. When they have understood that there is another way to approach this,
Mhm.
it brings a lot of peace and collaborative work.
Love that.
It
Yes.
brings back safety. It brings back
Mm-hmm.
a sense of connection between the mother and baby,
Mm-hmm.
and which is what we want, isn't it, Chris?
Yes.
That's
Yeah,
what we want.
absolutely.
We want them to
Absolutely.
feel bonded. We want them to not feel like every single time I'm doing some post frenotomy care, I don't want to traumatize my baby, but I
Yeah.
don't know what else to do, because it's going to then not prevent what I call as a reattachment, or
Right.
maybe scar tissue formation, for example. We want to prevent those. But to be
Yeah.
able to prevent that, I need to do these things which are essential. But how do I get cooperation from my baby? That's the
Right.
challenge a parent is going through. So the approach of bringing back collaboration, safety,
Mm-hmm.
and autonomy, I think, are game changers.
It sounds to me like that. And it sounds like really a beautiful, delicate dance between the baby, the mother, and the practitioner is also. And I love how you describe to respect the autonomy of the baby and achieve the goal that you want. Also, in collaboration, of course, with the parents to empower the parent and feel like a parent again and not wondering if the parent is doing something wrong and traumatizing the baby as well.
Yes.
Yeah, Yasmin, this was absolutely fabulous. I wish I could speak to you for hours. I'm so looking forward to this presentation. I'm so happy that you will be back at our Gold Learning Summer Day here at Gold. Thank you so very much.
Thank you so much. And I look forward to it as well.
So, a few words here for our audience. If you would like to find out more about this Summer Gold Learning Day here with us, we have 3 presentations planned for you. And check out goldlearning.com for more information about the timing. It depends on where you are in your time zone, right? And of course, all the presentations are accredited. So, we hope to see you there this summer at the Summer Gold Learning Day. Thank you, everyone, for watching, and have a lovely rest of your day wherever you are in the world. Bye bye, everyone.